and to give a little bit about what that looks like over time to sort of understand that. And in this particular situation, we actually chose a framework, one that Jen talked about yesterday, which is the I-Paris framework, where context really matters. All right. So we talked a little bit about that. So we're going to use an implementation science lens to review scaling up HIV prevention. We used methadone and buprenorphine. We are using our bundle of implementation tools, so a blended strategy called Niatex, which you heard to talk about. So we're trying to build upon each one of these sorts of things. And then really to sort of take a look at what do you do when there's really disruptions that come up and change the way that you do it. And unlike what Denise was talking about yesterday, where we have these beautiful cluster randomized trials, even a very high quality step wedge that she doesn't like, we didn't use any of that. We sort of used just really very basic data to take us through this. And I also just want to point out that it takes not a village, but it takes almost a whole country to do this sort of work. But over the years, because it's been many years, there's been a number of folks with my colleagues in Ukraine. Sergei Dvoryak, many of you may know, is someone that I met many years ago when we introduced buprenorphine into the country for the first time. I have colleagues from a large NGO, so we were having conversations about how do you engage the community and sort of bringing in others. I have colleagues from Yale who have actually developed their own independent projects there in the country. And then you're going to hear basically some papers from what I call really a stellar crew. And so, you know, this sort of collaborative effort, these are people from sociology, from behavioral psychology, from all kinds of different disciplines to do this work. This slide gets repeated, and thank goodness Luke did it, but essentially, I'm going to tell you what we did. So the thing that we did was we said, we want to take something that really works. We want to take opioid agonist therapies with methadone and buprenorphine. And this is where context matters, because we have over 60 years of evidence that this works, but it's what I call an Eastern Europe and Central Asia context, but it wasn't invented here. And so we have to reprove ourselves over and over again, despite the evidence. And so there's a tailoring that happens with that. We use Niatex, which is, you heard a nice extended conversation about it yesterday from Lynn, on this bundle of implementation strategies in order to do that. And I'm going to talk about the tailoring, how we changed this sort of implementation bundle in a way that was appropriate for this context. And our outcome, we tried to keep it really simple. We just used numbers. How many people are on treatment? And we did that because we know that WHO recommends that if you have X number of people who inject opioids, you want to get coverage rates of 40% in order to stop the HIV epidemic among people who inject drugs. And you need to get it down to about 20% in order to stabilize. And so we have really very objective goals in order to get there. And I consider myself a pragmatic. I actually love Luke's slide about how he sort of talked about practical and not. I consider myself to be a pragmatic implementation scientist, and I keep it really simple. I want to do whatever it is that we're doing better or faster or cheaper, or it could be all of the above. And I think that if all other things are equal, if you get one of those right, you've done your job from implementation. So I may not be able to do what I'm doing better, but if I can do it faster and cheaper, that is, get people onto whatever they need quicker so that they're not in trouble for that time period, that is an okay outcome. I won't go into the detail of all of these theories and models and frameworks, but we used I-Paris. And what really was important, I think that sort of required us to rethink the way that we did things, was the fact that the context was really different. And we implemented Niatex for the first time in a low and middle income country, and it required us to do things differently than we had to do before. And one of the things that I'm going to point out is when you're doing implementation, keep up with what you're doing, because if you're not doing what you want to do, you have to change it. It's the old Einstein thing, you know, doing the same thing over and over again and expecting a sort of a different results. So what's the evidence for what we have? We've got essentially, among people who inject drugs, we've got 4 evidence-based practices. We're going to focus on opioid agonist therapies. And I will say that opioid agonist therapies have a secondary benefit, and that it's very good at promoting HIV prevention as treatment. People with HIV who are on opioid agonist therapies, they improve at every single step of the HIV treatment cascade. And if you can drive people to viral suppression, no matter what risk behavior, it's really hard for them to transmit the virus. It comes from 22 randomized controlled trials. It works across a number of things. But one of the problems with this evidence-based intervention in this part of the world is that, first of all, they just didn't believe it worked. And the implementers, remember, the targets of your implementation are the clinicians who are prescribing it. And if they don't believe it works, why would they do this? So this was foisted upon Ukraine for HIV prevention. But guess who was asked to do it? The addiction treatment doctors, the narcologists. And so the narcologists are, why are we doing something? Well, we don't even believe it works for addiction. Now it does, but they didn't believe it did. And so you can think about some of the challenges that we had up front. And we talked a little bit about cost. There was really beautiful modeling before we introduced Niatex. If you take a look at sort of low coverage, moderate coverage, and high coverage for methadone, for antiretroviral therapy, and some combinations, what you do is that it's, this is something that works. We know how much it works. And if you can scale it up, your scale up at high coverage levels means that you actually really reduce a lot of HIV infections. That's cost effective. You actually scale up antiretroviral therapy, you reduce HIV infections, but when you combine them, you get a much, much better outcome at the far right. And then, of course, because methadone costs pennies, the cost for preventing one HIV infection is 1/4 the cost relative to scaling up antiretroviral therapy. So if you want to use something that's cheap and effective, you go for this. So one of the first talks that Luke gave is the question important? So it really sort of satisfies that question. Now, this is the context. This is Ukraine. It is driving to separate itself from the ideology of Russia at the time. My first arrival, this was the day or 2 days after I arrived in Ukraine the first time with the Orange Revolution. I could see, and George is emblematic of that as well. It is really driving itself to have a unique trajectory, which is really important because they are looking to sort of move towards a different sort of ideology, which is more towards the West than towards the East. And there are divisive sorts of conflicts around healthcare, and especially opioid agonist therapies. And this is where we started. I arrived in 2004. We introduced the first cases in buprenorphine. We got a little bit of a scale up. It kind of trickled along for many years. Buprenorphine was too expensive. Voila, we added a new treatment. We got methadone. We got a scale up. It plateaued again. And this is in a setting where you've got 360,000 people with HIV. There's approximately 346,000 people who inject drugs. Among 82% of them have opioid use disorder. But by the time that we got started on this, there were only 7,800 people on treatment, and it was flat, and it represented a coverage of 2.7%. The goal is, how do we get to 20, right? That's the direction. Do you have a direction that you're sort of moving in? And so in this setting, there was a number of structural impediments. They had rules that said you can get treatment. You have this complex process where you have to detox twice. I've got news for you. If you're a person with opioid use disorder, you never, ever want to detox. It feels awful. It feels painful. And you had to do that in a hospital setting. And once you decided that you were going to drink this Kool-Aid, this medication, you had to do it every single day by leaving your home, transporting to the site of treatment, taking your treatment and being mistreated oftentimes, and coming back. So that's what the landscape looked like. It was very rigid, a very vertical system. And what we did was, by the time that we were here, they had set targets. They wanted 30,000 people on treatment by 2015. So we decided that we were going to do that landscape and try to understand what were some of the barriers and facilitators. And we used a model that we talked about probably in 3 presentations yesterday, the socio-ecological model. And I have to tell you, what we did poorly was we interviewed in focus groups 199 people who inject drugs, 50 or so people. I mean, this was early in implementation science. I mean, we thought we were doing the Cadillac and we needed a Ford. So I would say, don't do what we did. But by golly, we learned a lot. We learned what were the factors that were going on at the individual level, interpersonal levels, organizational levels, community levels, and public policy levels included that. So we had really probably one of the more comprehensive landscape analyses that I've seen before, but we sort of knew what was going there. And I would say if I were doing this again, I would never, ever, ever do it like this again. But I learned a lot. What we did was one really interesting survey, and this is at the individual level, is we did something that's called item response theory. It's a very easy thing to do. And we really sort of took a look at the kinds of barriers. We had an exhaustive list that we had developed from our qualitative interviews, about 36 of them. We subjected it to item response theory. And what we really found out is the one thing that we hear every time when we talk to people, oh, you can't do this because it's stigma. Well, the bottom line is whenever you subject it to this, 86% of all the barriers were related to program logistics and entry challenges, which is why we chose something like Niatex in order to do this work. And what do treatment attitudes look like? And one of the things that we thought about was that if you can change the logistics and the entry challenges in a way that is beneficial for the patient and the provider, the attitudes will change. And guess what? The bottom line, I'm done. It did. So here's what happened. We got started in 2014. I arrived, I got on the airplane. I was flying into Ukraine thinking I was going to have a really productive day. I arrived, they changed my hotel because they said, guess what? We've got another revolution going on and we can't let you stay downtown because it's unsafe. They had sort of Black Friday. I showed up the next day with the American Red Cross. These are my photographs from the Molotov cocktails and everything that was going on downtown. And then by the time I left, which was 9 days later, Russia had invaded Crimea. And this is the work that we had to do under these settings. Facilitation, we were using Niatex that you heard all about yesterday. Lynn really has gone through all of this. Set a name. It was really simple. Increase the number of patients, have a number and series of change projects, use the 5 principles that we're going through here. You've got rules, use existing resources. You know, are you going to ask for manna from heaven? If you wait for people to give you the money to do it, you will never make a change. And so really moving with what you've got, expecting no more, but doing what you can with what you've got in order to optimize the outcome. Make sure you do all of the things that we talked about. Really, one of the things that required tailoring for us was the executive sponsor. So when we first started, we started with NGOs and people in the field, and they would come back to us and they would say, well, that's nice, but the head doctor isn't going to do anything because he's not involved in the process. You tailor what you do. You have to change because we were looking at the data and we said, oops, it's not working. Do something differently. And then, of course, these were all the tools that you heard about yesterday. This is our eventual Niatex collaborative. We came together a couple of times every single year. And then we had coaching calls every single month. They had change projects and we got to come together and we got to share ideas. And let me just tell you that collaborative learning was really important. And it's one of the things that we added to the secret sauce of Niatex. Collaborative learning was already part of it, but we tried to figure out, and I think we succeeded on how to measure it. How do you measure collaboration through a collaboration scale? Looking at that, and I'll talk a little bit about that. So these are some of our disruptions. Crimea was annexed. We got sort of involved with this while we were sort of analyzing what were the barriers and facilitators. We spent almost a year. Never, ever again. You get your barriers and facilitators done a little bit more quickly than that. We started Niatex. We used the data from our barriers to change some of the policies. Order 200, which was the guidance that said 2 detoxes, you have to come every single day, was changed. All of a sudden, people could earn take-home dosing for the first time, and we had done some early pilot projects doing prescription buprenorphine. That was part of that. We tailored Niatex, at least initially, by changing who the targets were from community-based organizations to the person who was in charge of getting the methadone and sending the message out. So we used the executive sponsors who were then sort of responsible for working within their region. And then we did something that was different. We used some behavioral economics. This is a low and middle income country. Money matters. These doctors who were doing this work were making on average $200 a month. And they said, why would I do anything differently if I can't pay for this? So we created challenges, and they were $500, $1,000 over the course of a year. I call it pennies, but to them, that was a huge amount of money in order to have an outcome. And what we did was we set the challenges, all right? We said, what is expected? A 20% increase, for example. We supported them through NIATEX, and we rewarded them if they achieved these various different challenges that were set forward. The other thing that we added was NIATEX does not have a training component, and it's a slight modification, but we created learning visits so they could see what happens outside of that institution. NIATEX brings ideas from outside the organization, or in this case, Ukraine. And this time we decided to reverse engineer that by having learning visits that would happen for individuals who were sort of maybe some of the champions, if you will. And then I'm going to move us up eventually at the end of the talk to what's happening since the invasion. One of the things with implementation science, I think there was somebody who asked a really good question. Well, what do you measure? You can measure a lot of things, but we decided to keep it simple. We had a national database of every single person who had touched the OAT system. So we had sort of a national registry, and it's really simple. The way that you get people to scale up is you either bring new patients in, you keep them from dropping out, and if you do both, of course, you can target one or the other, but your changes are really focused. How do you open the door? Maybe we'll give you same-day treatment. How do you stop them from leaving? We actually coached to these kinds of activities. How do you open your door and how do you keep it shut? All right, they were very, very simple. And so it made it easy. Now you can do other things. I said, well, we want to add HIV screening. A very good idea. And you'll actually see that we got 96% of people who actually got screened. And I'll show you some of the data for it. So let's go to what happens here. This was our trajectory. So we're not using one of Denise's very sophisticated models. It's pretty darn basic. We just said we used an interrupted time series to take a look at what happens before and afterwards. And it's not the holy grail. A good scientist will say, this isn't perfect. But remember, I started out by saying we were doing a pragmatic study. We did not have comparative arms, but we created comparative arms because we looked at how people engaged with our implementation strategy, which was NIATEX. And we said, what happens when you make a disruption? Our data changed order 200, and look what happened. The rate at which new patients were on treatment went up, and it's statistically significant. But let's break that curve up. Remember, that curve is divided into those people who enter treatment and those people who drop out. And then, of course, the last curve is with COVID-19. It goes up, and for the rest of the world, the number of patients just flattened out. I mean, in the US, we sort of staggered along and didn't do, really quite as well. In Ukraine, something happened, and we'll talk a little bit about it. So we actually created this sort of behavioral economics. This was the tailoring of NIATEX to a new context by creating a challenge, and we set it forward, and we had 8 of the regions. One of the things about implementation science that you heard from Verico yesterday is you have different implementation at each site. How they utilize the tools and the strategies are going to be completely different. And it's no different here. And so, you set up these protocols and these things and you think that everybody's going to do the same. They don't. And that's one of the beauties about implementation science. So we had one site that scaled up by 71% and 7 sites that scaled up over 20%. These were sort of what I called our sort of champions. You'll sort of notice that these are areas over here in the green that were affected by conflict. And so that is unfortunate. This is what happened with the change in order 200. They changed a lot of activities and they allowed treatment to be moved outside of specialty care clinics. And you heard Thierry's presentation yesterday on what happens when you move it to primary care. COVID-19, instead of making people wait 6 months for take-home dosing, they did it immediately, all right? Not for everybody, but only for people who they thought that were stable. And then we'll talk a little bit about the Russian invasion. So really, we recognize that there were differences. The kinds of activities, the change projects that happened in each region were different. It was tailored. It was from the grassroots up. They came up with their own sort of ideas. But what we did was we said, let's measure some of the activities related to Niatex. Did they show up at the meetings that were in person? Were they on those coaching calls and doing change projects? Did they adopt new things such as screening tools that actually helped them see how well they were doing? Did they learn from outside by being part of those international travel visits? Were there high levels of collaboration, which we measured? And we added something else because we saw that there were a handful of what I called cowboys and cowgirls. They were ready to do something new all the time. It was kind of like that shiny thing out there, but they didn't do the other sorts of things. They were risk takers. Yes, I'm going to be the first to do the buprenorphine prescriptions, but they didn't score as well on these other sorts of things. And so what we began to do is we created a factor analysis of actually a latent class analysis over who these kinds of 25 regions, how they were operating with regard to implementation. And you can see that, the good news is we get to name what these latent classes are. They didn't name it, but we created some categories based upon collaboration, leadership, risk-taking, and whether they did external learning visits with that. And remember, when they showed up at the sort of the regular in-person meetings, we added stimulus lectures. So this was an added tailoring of what happens there, because people would say, but that's not what you do with methadone. We were like, oh my God, there's no continuing medical education that happens. So we had to change what we did. And you can see that we've got our engaged collaborators, the more risk takers, what I call the independent operators. And my team wanted to call them the laggards as related to Rogers Diffusion of Innovation. But for the paper, we don't want to say that. We call it delayed adopters so that we could keep the same language. And you can see that there are different characteristics for these different groups in terms of how they late. So the question is when you have that scale up from the change in any disruptor, was there a way that they did things differently than they did before? Let's take a look. So we talked about what happens. I'm going to take that purple line and I'm going to disaggregate it based upon these three types of implementers. So what you see in the red, we looked at the two metrics, new patients. All right. Did they bring in new patients? The red line, they have a steeper rate of increase. We have the independent operators who are intermediate and the delayed adopters. But the news is they all went in the right direction. All right. Congratulations, you're going in the right direction, but do you do it faster? All right. And that's what's happening here. Let's take a look at the other part of that. Did their patients drop out? Well, the people who were the independent operators right here, they actually had a higher dropout. So they were doing all of the things to do something shiny and new, but they weren't paying attention to the other sorts of things. So they weren't tending shop, but they did well. I mean, they certainly did well. And then, of course, the independent operators were doing nothing different, and they were plodding along, but their patients didn't drop out because they weren't adding new patients. And then, of course, the engaged collaborators had the lowest rate of dropout because they changed and re-engineered the way that they did things by opening up the clinic. And the things that we coached towards were the things that we knew that would affect. So we coached towards, how do you move people safely to take-home dosing? How do you actually get people onto an optimal dose of therapy? One of the reasons why methadone failed in Uzbekistan is because the average dose was 25 milligrams. All right, so we know that probably the single best predictor of retention is dosing. So we coached to the things that were relevant for the evidence-based practice. We also found something also that's been really interesting. We looked at the HIV treatment cascade. 40% of the people on opioid agonist therapies have HIV. And we looked at a sample of those across the way. And you can see in the green, these are people who were on opioid agonist therapies, but because these sites had adopted as part of their change project screening for HIV, they also benefited even if they dropped out from OAT. So touching the system had a benefit that was sustained, not as good as if you stayed on it, but really better than the people who had never touched the system. All right, so you've got these secondary benefits of the implementation that have a secondary outcome and not just the increase of being on opioid agonist therapies. So let's go to the next disruptor. COVID hit. We had to do things differently than we did. And I have to tell you, we asked the providers, what is it that's worrying you? They said, oh my God, these patients are going to come in, they're going to infect our staff are going to get sick. They had these sort of public, edicts that said, we don't want people out on the street, please stay at home. And the government appropriately responded by saying, please safely move people to take-home dosing. But the doctors were deathly afraid of doing this because they said, if we give them take-home dosing, they're going to get stressed out and take all the medication and they're going to die. Legitimate concern as a clinician. They were also legitimately concerned whether there would be diversion, which would mean that you would see some increase in overdoses. And guess what? We said, all right, the government has recommended this. What do they need? Our coaching, we actually changed our coaching. We went from, at least initially, from monthly to weekly. So we met with them more frequently. So we tailored our implementation strategy. We basically gave them ways to sort of identify and monitor patients who were stable. We had them shift. They were afraid, legitimately. I'm a clinician. They called them up every few days and said, are you doing okay? Are you stressed out with your take-home dosing? Are you doing okay? And that made them feel more comfortable. But they didn't want to do it, but they knew that they needed to. They wanted to protect their staff. And so we changed our coaching and we actually tried to guide them on how do you do more accelerated dose raising. So they had like 5 milligrams once a week, increase it every couple of days, every 2 or 3 days. Everywhere else in the world, they do it that way. They changed the way that they did things so that they could get them to an optimal dose earlier. So the coaching was targeted to the outcomes that we wanted to have. And so we, as I said before, we gave them some stimulus guidance. The other thing that they asked for, which had nothing to do with scaling up OAT, but everything to do with keeping our doctors not scared to death, is we gave lectures on COVID. What's happening? What's going on with the epidemic? That was in some ways relieving to them, because when we screen them for stress levels, and we published this, their stress levels were off the roof, all right? They were really stressed out. I mean, and this is what happens when you have a disruption. You stress the individuals who are your operators within a system. So what happened very quickly? They had 53% of their patients on take-home dosing by the time that the provision changed. They moved them within the first 3 months to 84%. So you've got a 30% increase in take-home dosing. So your questions are, did you enroll or not enroll new patients? Did you keep them safe? And did you keep them on treatment? Those are your real 3 big questions. From an implementation perspective, we said, what is it that people really care about and what are they doing? We annualized this from the pre-COVID, the 1 year before, and we looked at what happens if you have to see a person 365 days a year and you just said to prepare the medication, to fill out the paperwork and see them, let's just conservatively say 5 minutes. It doesn't really take that long, just give them the medication, but let's just say 5 minutes, all right? I'm sorry, it actually probably takes them a lot more. What does that translate to? That translates to 86,000 hours of effort that was saved. Now, what do you do when you have 86,000 hours of extra time? You can do other things like bring new patients into treatment. You can call them up on the phone and make sure that they're okay. That also translated to 1 million decreased visits. Think about the demands. You all probably go into work every day. You probably face this Tbilisi traffic. These are demands that your patients are having to do just to get a medication to keep them alive every day. All right? It's huge. You reduce the demands, but you reduce the demands on the people who are implementing, the providers. Isn't that good that you have that sort of reduction? Now, the question is I do less work. Okay, is it cheaper? I'm having to do less work. Do you do it faster and do you do it better? So let's just take a look at what happens here. By the way, the other output, at least initially, this was a quick and dirty assessment. Mortality rate, annualized mortality stayed the same, at least at this particular time point, without looking at anything else. So what happens? We looked at the 1 year before COVID, and the second cohort prospectively was the 1 year after treatment. And you can see a number of things that were really important in terms of outcomes here. You've got more patients and who actually get on take-home dosing sooner in this particular setting. And what we said is, let's take a look at, first of all, retention. If you give them medications and they have take-home dosing, do they drop out? And the answer is you have higher retention overall in the group after COVID. So changing what you do, did it make a difference? What were the elements that contributed to that change? Well, the biggest predictor was actually moving them to take-home dosing, reducing the demands on the clinic staff, reducing the demands on the patients. A 30% difference prospectively of whether they had to come in every single day versus get take-home dosing. Now, there were a couple of other factors that predicted the retention on treatment. What did we coach them for? Getting them on an optimal dose, getting them up to 90 milligrams a day of methadone. If they were HIV negative, they were more likely to be retained. And if they had never dropped out from OAT before, that is, they're new patients, they were also more likely to stay. Past dropouts are associated with future dropouts. All right? And so we had that. Now, the other question is did we do benefit? We actually enrolled more patients per month because they had more time, so our rate of enrollment went up. We had lower dropout during the COVID period. Did we do harm? When we looked across the analyses, there was no difference in survival, which means that we did not do harm. We trucked along. We changed that sort of policy. The take-home dosing became much more liberal. They gave them 3 months, so they went from 6 months to 3 months. And then, of course, we have another crisis 2 years ago. We looked at a number of the sort of disruptors that were happening across the country. And this is where we were in terms of coverage just before the war. February 1st, 2022, you would see that we went from an average of coverage of 2.7% to 6% over a couple of years. And one of the things that you see is that initially, the number of patients on treatment dropped down. This is what happens whenever you shut down clinics and people get afraid or people move out of the country. There was a huge amounts of internal and external displacement, more so for women than for men because they could leave the country. The men were not allowed if they were of a certain age. And so you see that there was an initial drop of about 700 or 800 patients. The question is what happens? Did you allow yourself to hemorrhage or not? The government allowed, if you happen to be in a conflict region, you could have 30 days of medications if your doctor decided that you were stable. In some cases, they said, here's your 30 days to get to Lviv if you need to, or whatever it is. But this is, the whole idea of transferring patients was not allowed, and it took a 1-month process to do that before. These clinicians who were really engaged and knew how to change what they were doing, they had had 8 years of practice with Niatex about learning to be flexible. This is a part of the world that has never been flexible. All right, so they didn't have, sort of the last 70 years of being able to do this. This is all stuff that they had learned. But what you can see is that once they lost those initial patients, they actually increased, and they increased for a number of different reasons. One is they were really stressed out and people were moving and they said, I've got to stay alive. So there were new patients who were coming into treatment. But the other thing is because remember in 2016, treatment could be moved outside of these addiction treatment centers. There was a whole private system of patients who were on buprenorphine who would get prescriptions from the pharmacy. We weren't monitoring those, but all of a sudden the pharmacies shut down and people said, I need my treatment. So there was a second source of treatment getting them into the government clinics. And we didn't have a really good way for measuring that, to be honest with you. But what we did was these were our sort of coaching calls we would get on a regular basis and really sort of work through a lot of this work. And what was really remarkable is the resolve of these people who were just working, and this commitment was, we are going to keep our patients alive. And one of the things that I want to say from my personal perspective, it is a testament that the people of Ukraine cared about the most vulnerable people there. They weren't just screaming, oh, we have to take care of our cancer patients. We don't have to just take care of our pregnant women, sort of the usual high priorities. They cared about the most marginalized people. And the reason why I believe, I mean, I could never examine this, is that these people had become collaborators. They were engaged. They were sort of doing this work together as a team. And they decided that they would continue that because they had support. We had developed a network. They were on calls to transfer patients by phones. They developed WhatsApp groups in order to communicate about moving patients and stuff like that. So they had the ability to transform during a time when most people did not. Now, these are some of the early responses of what they did. They were so creative, part of the coaching calls. Does this sound like a good idea? One group had this whole message. They put every single one of their patients on a WhatsApp group or a Viber group. And they said, all right, the sirens are going to be off between 2 and 4. Everybody come and get your take-home dosing today. They would sort of let them know when it was safe to leave their homes in order to get treatment in some of these areas. These were other disruptors, and I will say that there were other heroic things, but I don't want to spend this. But what happens, and you all know this, I'll be done in 5 minutes, don't you worry, is that we have these sort of conflict areas over here that were occupied by Russia, and then we had this whole movement that happened. And this is a paper that was just accepted as a late breaker at the International AIDS Conference by one of our postdocs. You got to hear Atiri yesterday. This is another sort of stellar postdoc who's from Ukraine, who did this work, and he defined regions. So they were occupied regions. This is what I call the peri-conflict region. So they're right on the edge. You know, these are people that want to run, theoretically. You have people, what I call the short-term safety. I don't know what the word in Russian would translate to, but somehow he used the word target. So, you know, I don't know what that necessarily means, but it's the nearby regions. And then what I would call the more remote, safe regions. And this is where they were. There was about 28% of the people who were in these sort of conflict regions, either occupied or in the peri-conflict regions, in the gray. About half the patients were in this sort of middle zone, which is where a lot of people moved. I mean, it's hard to move to Lviv. And then, of course, there was about 20% who were over in the western regions, less populated, less people who inject drugs generally. But what we had was that the dropout overall was at least for 10 days. Dropout is 10 days off of treatment. That doesn't mean you don't go back on. But any kind of dropout was 29%, all right? There was a lot of people who dropped out, and there was a lot of movement that happened. We had 819 internally displaced persons. And one of the things, when you sort of look at any dropout, that is a 10-day, doesn't mean they get back on treatment, but any kind of dropout was associated with being in a frontline region that is near the conflict. If you were frontline and internally displaced, you had the highest rate. The patients on buprenorphine, there was less of it available in the country. There was a higher dropout if you were on buprenorphine. If there was a lower dropout if you were on an optimal dose of therapy, which means that you were safer and you were doing more well and you were more compensated. There was lower dropout if you were on take-home dosing. And then there was a higher dropout if you were HIV. And so this is really an interesting way of look at what happens during the time of conflict when people actually have to move in a system that is not used to having people move. There were a number of things that happened. Some of the private clinics would actually sort of share patients and work with the governmental clinics. I mean, these were people who hated each other for the most part beforehand. They changed what they did. And in fact, what happened was the private clinics, who had this really beautiful clinic, I have to say, it was really nice. They said, your doctors and your patients can come over to our site because you all don't have a safe enough place to store it. So they changed what they did. This was in Kharkiv, which is one of the sort of the near conflict regions. And I just want to say that this is sort of emblematic. This was actually soon after the conflict. This was International Women's Day, and I was presenting to the United Nations, and these women wanted to send me a picture to really show their commitment. And of course, many of you certainly may read Russian, but on the bottom, OAT equals life. And then this woman, they remembered Crimea, Lugansk, and Donetsk, the Donbass region from 2014. And what happened, 10% of those patients in those regions died within 6 months. And then they did not want to disrupt treatment, and they were going to do anything that they could in order to do that. So in summary, what this means is when you're doing implementation, whether it's within a science project or a pragmatic implementation, you oftentimes have to change what you're doing, but you have to record those temporal changes so that you understand what's going on and what people did differently in terms of the clinics and what we did with our implementation strategies within Niatex. We changed Niatex to the context by providing international learning, education and training, international learning, and stimulus lectures at our quarterly lectures. So we changed the way that we did it. And those activities were central to the different ways that scale up happened using Niatex. I don't know how many questions I'm allowed to have, but I'm going to stop there. Thank you so much.